Today, we're very pleased to have Deepti Gurdasani on our channel from UK, one of the key figures behind the Jon Snow Memorandum, and we're going to talk a bit about that, different strategies for facing the pandemic, the new mutations, and also a bit about schools and transmission there. Welcome, Deepti.
Thanks for having me.
A great pleasure. Deepti, so most people, at least here in Sweden, I think they're not aware of what is the Jon Snow Memorandum. Could you explain what that is and what made you initiate that?
Yes, sure. So the Jon Snow Memorandum is essentially a document that outlines scientific consensus, so the agreement across the scientific community on what we currently understand about the SARS-CoV-2 virus, which causes COVID-19, as well as our understanding on the measures that we can take to, for example, reduce or mitigate risk. The idea of putting together the Jon Snow Memorandum was essentially to present a consensus of what we understand about this disease. At one point in time, we were hearing a lot in the news about having scientists divided into two camps on how to tackle COVID-19. And most of us in the scientific community felt that this wasn't an accurate reflection of what was happening, because most scientists actually clearly agree on the risk posed by this new coronavirus and the disease that it causes and what we need to do to tackle it. Although there is a small fringe group of experts that have arisen and spoken about other strategies, for example, naturally acquired herd immunity by letting the virus spread across the population. These are very much in the minority. And as scientists, we wanted to really articulate that most scientists actually clearly agree on the evidence out there and what we need to do. And the Jon Snow Memorandum was actually co-authored by about 80 world-leading scientists from across the globe, and subsequently signed by over 6,000 people, 6,000 scientists, public health professionals, and healthcare workers across the globe, showing the level of support that it had in representing a real consensus of what we understand about this disease.
Yeah, fantastic. I did also sign it, and it's really an impressive list of key persons you managed to find there to sign that. So very well done. Many people perceive this as some sort of reaction to the Great Barrington Declaration. Was it like that, or did you have this in the pipeline independently?
Well, I'd say it's not really a response to the Great Barrington Declaration, because the Great Barrington Declaration, of course, didn't have any evidence behind it. It wasn't really published in a peer-reviewed journal. I think it was more of a response to a lot of the thinking that we were seeing in the mainstream media as a result of the Great Barrington Declaration, which is that scientists are divided, and that was sort of reducing public trust in our understanding of the evidence, and also in our ability to collectively respond to the pandemic. So that led to a group of us really wanting to put forward a clear idea of what the evidence was showing and what people actually agree on, while acknowledging points of uncertainty. And that was the motivation behind it, to really present an agreement in science on this. But as part of the memo, and if you've read the memo, you know this, we also tackled some of the arguments of the Great Barrington Declaration, which are not based in evidence, and showed why they are flawed and unethical and would lead to a lot of deaths and a lot of morbidity in terms of long COVID. So that was very much part of the document, but it wasn't the whole purpose of the document.
Okay, and for listeners who may not know these declarations very well, let me summarize here very briefly. So basically, there are two, very coarsely put, there are two main strategies that one can take against the coronavirus. One is called mitigation, and the other one is called suppression. Mitigation is like what's been known worldwide as the Swedish path, where most people tried suppression, which involves lockdowns and harder measures. Is it fair to say that the Great Barrington Declaration was a scientific call for the world to follow more like the Swedish path, to let the virus spread and acquire herd immunity through natural infection of the healthy part of the population, whereas the Jon Snow Memorandum supports the suppression strategy with more government intervention and
I think the Great Barrington Declaration actually outlined something even worse than that. So what it outlined was the idea of focused protection. So it said that we could, for example, take vulnerable people and sort of shield them and protect them absolutely so that they don't come into contact with anybody else. And then let the virus spread across the rest of the population so that, everybody would develop a level of immunity that would then protect this subset of the population that had been shielded.
right.
Of course, we highlighted the many, many problems with that thinking in the Jon Snow Memorandum, particularly the fact that, different countries have obviously tried shielding vulnerable people. I mean, that's been a key part of almost every country's strategy across the world, but none of those strategies have been able to compartmentalize sections of the populations to the extent to prevent transmission to those age groups. And ultimately what we always see is transmission spreads from younger people into more vulnerable populations and elderly age groups, which always leads to more death. And the other thing that we outlined was that even for so-called young and healthy people, high levels of transmission going through vast swathes of the population is not a good thing, because we know very much more about the virus now, and we know that the virus isn't like flu. It can cause long-term effects on people. We know between 10 to 20% of people at least, and including those with even mild infections, can have long-term effects lasting for more than 12 weeks. So given all that, we made the case that a strategy like that would not work. And actually that has been borne out from our real world experience, because that sort of strategy hasn't worked in any part of the world. And the Swedish strategy is probably not exactly that, but
it sounds exactly what it was here. At least that's during spring, that's how it was sold. Let's protect the elderly. They said we're not aiming for herd immunity, but it's a positive side effect of what we're doing here. And then when it wasn't possible to protect the elderly, they were blaming the elderly care for that. But as you say, it has not worked anywhere to protect the elderly, because it's simply utopia that you can't reach. So the Great Barrington Declaration, it comes from, it was signed in a place called Great Barrington, somewhere over in US. It's a rather strange name. And the Jon Snow is equally strange. I mean, where does that name actually come from?
So the Jon Snow Memorandum comes from Jon Snow. So Jon Snow was one of the epidemiologists who's considered really prominent in this field, who first is thought to have identified, I think, the source of a cholera outbreak by kind of using public health and epidemiological principles of trying to follow, where an outbreak came from. So it was very much, to acknowledge that contribution of Jon Snow in that aspect. So yes, no, it wasn't named on any place. It was very much to kind of show the public health and epidemiological thinking and principles behind the Jon Snow memo.
But so you say, it's very interesting. You say that the motivation behind the Jon Snow memo was to show that there is scientific consensus here about what to do, and that somehow the public narrative was that the science community is divided. I would say that inside Sweden, that's very much still the picture we get. And also, actually, if you listen to Swedish, at least the Swedish people in media who get a platform, it's half-half on each side. So it looks like that there's no consensus whatsoever from inside Sweden. Would you say that you were successful in achieving that? I mean, how many people signed the Great Barrington and how many people signed the Jon Snow?
So I don't know if we were successful in achieving that. I think we had a degree of success. In terms of numbers, I think it's possible actually that the Great Barrington Declaration may have had more signatories than the Jon Snow memo, but I think it's not just about the number of signatories. I think it's the fact that the Jon Snow Memorandum was actually backed up by very rigorous evidence, and the people who signed it were essentially world-leading scientists from across the globe, whereas the Great Barrington Declaration was signed by many people who didn't have any expertise in epidemiology and public health. In fact, even if you look at the core signatories, very few of them had expertise in this area at all, and it wasn't peer reviewed and published.
Right.
Whereas the Jon Snow memo was published in the Lancet with all the evidence published behind it.
Right.
I think the other thing to consider is that the Jon Snow memo didn't have any conflicts of interest. We were not funded by any group at all. This was just a group of scientists coming together and putting together a consensus. Whereas the Great Barrington Declaration was funded by the American Institute of Economic Research, which we know has been funded by the Koch brothers, and was really publicized using a PR platform that has in the past been used to publicize theories around climate change denial and other things which are in the interests of libertarian organizations. So the American Institute of Economic Research is a libertarian organization and actually funded the platforming and the promotion of the Great Barrington Declaration, whereas the Jon Snow memo had nothing like that behind it. It was just a group of scientists who came together and put it together, published it, and signed it.
Right. So let's say so these two declarations, it's basically about suppression versus mitigation. Let the virus run free through the population or try to smash the curve down. Right now we're in a full second wave in various countries through Europe. Some are trying lockdown to various degrees of success. I mean, well, what's your overall take? I mean, which strategy is countries actually following now? Are they doing suppression or mitigation?
To be honest, it's very hard to know. I mean, many scientists have recently got together and asked for a pan-European coordinated strategy to focus on elimination of the disease, like countries like New Zealand and Australia have done, rather than, follow the strategy of focusing on, for example, hospital or ICU capacity, because it's very clear that that strategy doesn't work. And it doesn't work for many reasons. One, when we think about, focusing on flattening the curve just to keep cases under hospital capacity, usually that doesn't work because cases surge much higher than we anticipate. Keeping high levels of community transmission with our levels around 1 is not something that any country has managed to do so far. We always see surges in cases and repeat lockdowns. The other problem with the strategy is that we are essentially tolerating a level of deaths, because once people go into ICU and hospital, while we now have treatments that improve outcomes and reduce mortality, ultimately we cannot do as much about people who've gone into hospital as we can do by preventing transmission altogether. So if you look at the death rates. So, for example, the death rate in the UK currently is about 1,100 per million population, whereas the death rate in a country like New Zealand is about, 3 per million. 3 per million population, and even lower in Vietnam and Taiwan, whereas less than 1 per million population. So, those strategies have clearly come on top, not just in terms of reducing deaths, reducing transmission, but also in terms of economy. I mean, one of the reasons the Swedish model was promoted early on, because it was thought to be beneficial to the economy, with maybe some cost to public health or no cost to public health at that point in time. Now we've seen that this sort of model doesn't just result in more deaths and huge impact on public health. It also results in a negative impact on the economy, because you end up in a cycle of repeated lockdowns and uncertainty over a long period of time, versus going hard and fast early on and controlling the pandemic, after which you can open up and people can have confidence to kind of be part of the economy.
They have compared the Nordic countries, Sweden and the other ones, and actually Swedish economy fared absolutely no better than our neighbors, who are successful, still are pretty successful with their suppression strategies. And what's also not mentioned in this is the immense cost of rehabilitation for all the long COVID patients. But I was thinking I'm going to put on the devil's lawyer hat and argue against some of the things you say. I was listening to Freddie on the Unheard channel, and I'm pretty sure that what he would say is lockdown sounds great, you smash the curve down, but as soon as you lift that lockdown, boom, the cases go up again. So what is then the point of doing this over and over, since it's actually, and also you're talking about deaths, But what these people then argue is always that, but lockdowns causes suicide, lockdowns causes child poverty, lockdowns and so on. So you put like deaths of these people against deaths of this other group of people. So how would you respond to that kind of criticism?
So I would respond to that in two ways. So yes, lockdowns bring down cases, and cases can surge after lockdown if you haven't done the planning that you need to do during lockdown to prevent those surges, and if you ease lockdown early. So there's a huge difference between the lockdown strategies that have been used in Europe versus the lockdown strategies that have been used in Australia and New Zealand. So the purpose of lockdown is essentially, one, to bring cases down to an extremely low level so that you don't have community transmission. And once you ease lockdown, you have methods in place to detect outbreaks quickly and stamp them out before they become entrenched in the community. So essentially, that time during lockdown needs to be used to put in place things like good, find, test, trace, isolate, and support systems to make sure that once we ease lockdown, cases and outbreaks can be managed very, very quickly and prevent onward spread. Now, this has been done successfully by some countries. So New Zealand and Australia, for example, used their lockdowns in this way to really bring down cases. They didn't go in for an early easing of lockdown when transmission was high because they were focused on elimination. The way Europe has used lockdowns is essentially they've locked down, and when cases have come below a certain level, but not low enough, they've started easing lockdowns. They've not had good surveillance systems in place and good travel restrictions, quarantine restrictions, and other measures like widespread mask use in place to ensure that cases remain low, because not just about bringing cases down, it's about maintaining cases down, which is something that I think we failed to understand, which has led to a repeated cycle of lockdowns. It's not because of following evidence that we are in this repeated cycle of lockdowns. It's because governments haven't been following evidence. And the second thing I would say about the impact of lockdowns, yes, the impact of lockdowns is damaging, which is why we need to prevent having repeated lockdowns. And the only way to do that is to focus on elimination. If you don't focus on elimination and you have a mitigation strategy, you are stuck in an endless cycle of lockdowns. But having said that, I also want to say that if you look at the excess mortality in many countries, so for example, in the UK, we have about 70,000 excess deaths within England and Wales. And almost all of those excess deaths are actually explained by COVID-19. So while there may be a rise to an extent in deaths, indirect deaths as a result of lockdown, the majority of excess deaths that are occurring during these periods are still because of COVID-19. So essentially, if you want to prevent these deaths, the best way to prevent them is essentially to get rid of COVID-19, because healthcare services cannot function with COVID-19. If you want to prevent your health services from being overwhelmed, the answer is not to let COVID-19 run wild. The answer is to eliminate it so that you can provide routine care. Letting COVID run wild is not going to reduce indirect mortality. It's going to increase it.
Okay, but you mentioned contact tracing. So here in Sweden, we don't do much contact tracing at all. Yeah. And one argument for that you hear is that, but look at England. They have a good contact tracing program, and it goes skyrocketing. Every time they ease restrictions, it goes up again. So contact tracing doesn't really work.
Okay, so we don't have a good contact tracing system in England at all. So the contact tracing system in England is, even by our own scientific advisors, having a marginal effect because it's so inefficient. And the reasons for that is, one, testing takes much longer than it should. So for example, you need to test people within 24 hours to initiate contact tracing to catch them, before they transmit to others. During October, for example, only 15% of people were being tested within 24 hours. Then let's look at contact tracing. So of those 15% who were being tested within 24 hours, 1 in 5 of those didn't even have contacts so that we could trace their contacts. We didn't have a contact number for them. Of the remaining 80%, we need to actually trace about 80% of their contacts within 48 hours to have any kind of an impact. So of that proportion, we were...
Yeah, no. You had me by the 15%. As I said, I'm... Oh, crap. This is very annoying. I'm sorry about that. I'm going to turn this one off. what was I saying? Yes, I'm actually getting quite specialized in using these Sayre type compartment models that you use for modeling the disease. And I mean, to make any kind of effect on where these curves are going, you need to affect, I mean, whatever you do needs to affect the big chunk of people. If you have some even 10, 15% like that you don't catch, that's enough for the spread to take off again.
Is even worse than that. So apart from missing about 50% or more of contacts, even the people who are asked to isolate, only about 20% or less comply with isolation because they don't have enough financial support to do it. So when you look at all this cumulative dropout, the impact it's having is so low that it's almost not recognizable.
Right. Yeah. As a curious note there, you said that you need to test quickly in order for this to work. The standard time in Sweden to get a test result is 1 week.
We've had similar times here at points in time when we were above capacity. But the median time can be quite long, also depending on whether it's a home test or a drive-through test. So it can be about 3 days or so, which again makes it far less effective in terms of contact tracing and isolation.
Yeah, I would go as far as question the point of having testing at all. I mean, if I feel sick, that's the usual reason why you go and test, right?
Yeah.
Then I'm already in my infectious phase, and I have to wait 7 days to know whether I am actually sick of this. And given that I have a job, I need to go to the supermarket, blah, blah, blah. Of course, during these 7 days, I'm going to convince myself that, it's probably not COVID.
Yeah.
And by the time I get the test results 7 days later, I'm no longer infectious. So what is the point?
And your contacts have probably gone and infected other people as well. So
yeah. I mean, you don't contact trace before you have a reason. A result. So yeah.
And also most of these methods, they don't do sort of backwards contact tracing. So it's all about the people you've infected, but it's not really about identifying where you've been infected and kind of identifying those clusters of infection and where they're coming from. Like, for example, the strategies for contact tracing are much more comprehensive in much of Southeast Asia, for example, in Japan and South Korea, where, they identify real clusters of transmission where they're coming from, which really helps finding many more people in the network of transmission versus the
right. So you go back a bit on the same branch and then find other branches before they are.
They don't just ask you who you've come in contact with after you got symptomatic or in the last few days. They also ask you who you've likely come in contact with before that, in terms of who you're likely to have got infection from, and contact those people as well. And then, link the data to understand how this transmission is happening, where it's happening. So, it also gives really important public health information to inform policy.
Yeah. And clearly, I mean, the way Japan has been very successful in keeping their curve down, despite having a fairly open society. But here, this really underlines what you said. I mean, what you're explaining now clearly is impossible if you have a high society spread. So this you can only do if the amount of people is kept at a very low level, because it's way too expensive and time consuming otherwise.
Absolutely. So it's not a strategy to bring down cases from a really high level. I mean, that's why people have to put in place lockdowns. But the idea is that once cases are brought down to a really low level, then these strategies can help maintain cases at a low level or essentially, keep them at a zero level, very much like other countries, New Zealand and Australia have done, and Southeast Asia.
So moving on. So there's been this great debate about Sweden. Worldwide interest in Sweden has been skyrocketing during the pandemic, because Sweden, there was this there's lockdowns, they're highly unpopular, and then letting it free is also unpopular, right? Because people don't want to die. And then in all of this, there was Sweden that somehow claimed to be doing some middle path. And well, our death toll in the spring was very high, but then it was actually calm for a long period, with our state epidemiologist Tegnell and his advisor Giesecke appearing on Heard and all sorts of media platform, telling the world how great is the Swedish strategy. from your perspective, how much has the Swedish path affected what's happened in other countries?
I think it's had a huge impact. So, as a scientist who does a lot of public engagement, whenever, we engage with people about the need for restrictions or, even when cases have risen, the need for mitigatory measures or lockdowns, what we are always told is this doesn't really exist. We should just open up like Sweden because look, Sweden is doing so well. And while we repeatedly warned that Sweden would definitely see a rise in cases, I mean, the rise in Sweden was later and the drop was later. So the surge would again be later. And we were confident that Sweden would see a rise in cases. And at that point in time, we were told that that would not happen. Once Sweden started seeing a rise in cases, we pointed this out and we were told, oh, it's just in young people and it's not going to lead to more hospitalizations and deaths. And we kept saying, look, there's a lag between cases and hospitalizations and deaths. And we've seen this in every single country across the world, and it will happen. But again, we were not believed. And our own government, for example, invited Tegnell to advise on policy at a critical point in time where people were dying in tens of thousands. Right. And our own scientific community, a scientific advisory committee had suggested a lockdown. But we didn't lock down at that time and lost many, many more thousands of lives. Rather, we decided to listen to people like Tegnell and listen to people like Carl Hennigan and Sunitra Gupta, who were really opposed to lockdowns on the basis that they didn't have any effect and we didn't really need them to prevent deaths. So I think the Swedish strategy and the kind of rhetoric around it, the idea that, it's been an intelligent strategy to prevent lockdowns and, doesn't have a huge impact on public health has hugely impacted, I think, the scientific policy in other countries. And I think is responsible for a lot of deaths across the globe because people in government have been listening to this and thinking it's a sensible strategy, but it isn't.
Yeah. Yes. Yeah. I'm sorry.
It's not your fault. At least you're challenging it.
There's always, when you travel abroad, people get Sweden mixed up with Switzerland. And I always have to explain that, no, those guys do Toblerone, we do Volvo and Scania trucks. But next time I get, mixed up with a Swiss, I think I'm just going to let it pass and nod along. Jesus. So I want to give you an update on the Swedish situation right now. But before that, a bit of a science question here. So one thing that really puzzled us, me and my colleagues in our scientific group here, was that when cases started to rise all across Europe, but also in our neighboring country like Denmark, it was still calm in Sweden. It was calm for about another month, by which even I started to doubt that if maybe I had been, wrong all along. And it seemed like this futile, 10% immunity level, which we got from the first wave. 12 estimates range, but it's way below 20%. Let's put it like that. It could even be below 10. We don't really know. But do you have any sensible explanation for why the pandemic waited another month for taking off in Sweden?
I mean, I don't know. It was during the summer. So one theory might be that, there was less potential indoor socializing. I mean, the other thing we've seen across pandemics are that, they come and go in waves, and generally the later decline, the later the rise. And, we've seen that they don't occur in sync. So for example, the UK pandemic was delayed relative to, let's say, the Italian one early on, and, France and Germany as well. So, I anticipated that the Swedish wave would happen a bit later because the declines were much later. And as anticipated, we did see this. I mean, I don't think that we would necessarily see, surges coinciding across countries in that way. I think it very much depends on the dynamics within a single country, and you can see surges at different points in time in different parts of the world. I think what's easy to recognize is inevitably once restrictions are eased, and unless there is something in place to prevent rises will be seen. But they may depend on what point of the year it is. They might depend on whether it's summer or winter, depending on, how people are socializing and aspects like that. They might depend on schools being open or not, things like that. But inevitably, once restrictions are eased, cases will always rise unless we have other systems in place to control them. And unless most of the population is immune, which of course hasn't happened anywhere. So we haven't had a chance to really look at that. Oh, sorry, I wouldn't say it hasn't happened anywhere. We have seen in Manaus, for example, where we think that 76% of people were infected, but we still see transmission continuing, and we still see an R of around 1. So it's not eliminated the pandemic in any way.
Right. Yeah. Okay, so update on the Swedish situation. It's been our testing capacity hit the roof, so it's been going up dramatically. And right now, intensive care units across the nation are actually full. They're storing what should be intensive care unit patients in like food, like restaurant sections of the hospitals, blah, blah, blah. In Lund, where I am right now, the intensive unit for children is full. And that's a huge university hospital, so on. So right now, the situation is, I would say, the worst that we ever had. In the spring wave, in the spring wave, many people, elderly, were not allowed access to qualified care. They were left to die on morphine. I don't know to what extent that still is happening, but that the child intensive unit is full. This is not good. And on Monday, the schools are opening again. So restaurants are open. We have never done anything close to a lockdown. There are like recommendations, like if you go to the restaurant, there has to be a certain distance between the tables. You're allowed to be maximum, I think, 4 people at the table. Major gatherings have been banned if they're organized by some public event, but if it's a private wedding, you can be 200 people still. And yeah, you can sell alcohol, but only up until 8 o'clock. So after 8 o'clock, you have to stop doing that. So, right. And that's where we are now. And now we had this long break for Christmas. And it seems right now they were saying that maybe like schools from 15 and up are going to close. Okay. As opposed to only universities. Universities that went to distance teaching, and now they're talking that, okay, let's move that down to 15 years and up instead. Or I think they decided that, or possibly down to 12. There was some sort of municipality could decide. But primary schools are kept open anyways. And society in general is kept open. Does that sound to you? We're from an epidemiological perspective, are we doing mitigation or are we doing suppression here?
I don't know if either are happening actually, because it sounds like cases have been rising very, very rapidly, and it looks like hospitals are at capacity. I am quite surprised to hear about what you said about children, because normally we wouldn't expect intensive care for children to be full. Certainly that's not the case in the UK, despite very high numbers. But I'm sure that, adult ICUs will be at capacity, and that's hugely, hugely worrying. And, with schools is a really important point, because, schools, it's very clear, contribute to community transmission, because it's an area where a lot of contacts happen and a lot of different households are brought together by children linking sort of those infection chains. And it's very clear from evidence across the world now that we need to make schools safer. So we clearly need mitigatory measures in school to reduce community transmission. And at this crucial point in time, where you already have hospital capacity overwhelmed, to have restaurants, public spaces open, it makes absolutely no sense, because we know that there is actually a gap between infection and hospitalization. So if we were going to act today to impose restrictions, that would still take 2 or 3 weeks to have an impact on hospitalizations, and even more on deaths, which means that hospitalizations would keep on rising over the next 2 or 3 weeks. So it sounds like what you need is actually urgent action to actually reduce cases very, very quickly, rather than leaving society fully open, because things are only going to get worse. This is predictable. We've seen it again and again. And it follows the same mathematical patterns. And unless we break that, things are not going to change, and there's no point hoping that somehow what's happened before will not happen again.
So, as an epidemiologist, if you were to advise the Swedish government, can we rank these things, like closing the primary schools, closing restaurants, gyms, bars? Which one is more important, or what measures have the most impact, you would say?
So, I think the measures that have been shown to have more impact, at least at a global scale, are one, reducing the level of gatherings. So that sort of social distancing, reducing mass gatherings to the smallest number possible. School closures are very effective in reducing the R number, but of course that has to be balanced against education. But there's no reason that schools, for example, cannot move to remote learning or blended learning setup. The other measures that have shown to be successful are border quarantines as well, which are really important, particularly in the context of this new, more transmissible variant that's spreading in many parts of Europe. Because although
right,
sorry,
to cut you out, I'm going to ask you about that one. But the border, I think Swedish people can. We even closed the border to Denmark, which was a bit weird because we have more cases than the Danes. But I think that was more like them doing something to make it seem like they're doing something, rather than doing something that would actually affect the development of the pandemic inside Sweden. But getting back to the actual question, what's more important, schools or restaurants? If you have to pick one, which one would you pick?
I think the current evidence shows that schools contribute more to transmission. Of course, there's a bigger impact possibly of closing schools and closing restaurants on society. So I think those things do have to be balanced up. But, like I said, schools don't need to be closed. Schools can move to remote learning for a period of time while we get on top of the pandemic, and schools can be made much safer during that period so that when they open, they don't contribute as much to transmission.
Right. That does seem like... because it's not only about, people like to get this discussion very binary. Either you close the schools and the children are home, like not learning anything and being malnutrition. Of course, there are so many ways to keep a school open, but reduce the transmission in the school. For example, not having the kids eat together in the main dining hall, or mixing between classes, stuff like that. Things which are not in place in Sweden yet. But I'm putting on my devil's lawyer hat again. I was reading a report from the Imperial College about that they've done some like meta-analysis on transmission in schools. This was, I think, their analysis 38 or something. And I'm just reading from their summary here. So they've identified 2,700 potential studies, singled out 128, and actually gone deeper into 99 of them. And what they write in the end is, we did not identify any studies designed to assess transmissibility in children, and found that susceptibility to infection in children was highly variable across studies. Children's susceptibility to infection and, is the key point, onward transmission relative to adults is still unclear and varied widely between studies. So they're basically saying there's no consensus here.
So I think this reflects the limitations of evidence that people have used to inform these sort of discussions. And I think we have to separate susceptibility. So susceptibility is, if you have the same amount of exposure, how likely are you to get infected, from transmission, which is how likely are you to spread the infection to others.
Right.
And you can be less susceptible and still spread more, for example, if you come into contact with many, many more people. So I might have half the susceptibility of somebody else, but if I go to a school and come in contact with 300 people, because
Yeah.
I'm part of a very big bubble, which is what happens here in the UK, I could still be more likely to bring infection into my family than other members of my family who are just going to work and coming into contact with much fewer people. So I think we need to separate that out. And the second problem with many studies that have looked at this have essentially looked at sort of contact tracing based on testing, which is based on symptoms in most countries. So, for example, you might have a child who's in school who doesn't have symptoms. We know that most children who get infected, many of them are asymptomatic. So you wouldn't necessarily expect them to get symptoms and be tested, but they can still transmit infection. So this child may go into their house, transmit to somebody in their family, or may transmit to somebody in school, and that person might be picked up by testing because that person develops symptoms. So the conclusion there is the child wasn't infected. The person who was infected was the adult, and children are less susceptible to infection and less susceptible to transmitting, because often children who are what we call index cases, so the cases who actually bring infection in either into a classroom or into their household, are not picked up. They are often picked up either as the contact of somebody else who was infected, or they're not picked up at all, which is the huge limitation with these studies. Which is why if you look at studies that look at the impact of school closures on our rate, which are not biased by all of these factors, because they're essentially looking at over time, if you close schools, and if this closure is separated from other interventions, what is the impact of this closure versus other interventions? That kind of gives you a composite measure of all these things and tells you how much schools contribute to transmission. And of course, this might be different in different parts of the world, which might have different mitigatory measures or different class sizes. And there is likely going to be a lot of variation. But if you look at the breadth of evidence, it's generally consistent that when you close schools, our rates go down. And when you open schools, our rates go up. Although there might be a variability in the extent to this happens. And it also depends on what the background transmission is in where you live. If the transmission is low, you might not see outbreaks in schools. But if the transmission is high, the possibility of seeing super spreader events or outbreaks are much larger. And that's what we see.
But in a high infection rate scenario, what would you say? Okay, so it varies a lot between countries and blah, blah, blah. But just guessing from the evidence that you have seen, what's the impact of school closures on the R value, let's say? Or
Sure.
Can you give a percentage of like how effective is this as a measurement?
So generally, it tends to reduce the R rate by about 20 to 35%, which is quite a significant reduction. If you look at the scientific advisory body in the UK, their estimate is that it reduces R by about can reduce R by about 0.5 when R's are high. So, it can have quite a significant impact on reduction in transmission.
So a nerd question here. When you say reduce by 0.5, you mean like minus 0.5, not multiply by?
Yeah.
50% you subtract.
Yes, exactly. But of course, when we talk about R in that sort of minus plus way, so in an additive way, it obviously also depends on the original R. Of course, if your R is
it's a it's a complicated problem.
Perhaps the multiplicative ones are more kind of reliable because they reflect that original baseline R value much better.
Good. And now the new virus mutation with the fancy name B117. It sounds scary to me. How much of a game changer is this in your point of view?
It's a huge game changer, and I don't think it's receiving enough attention in terms of policy, because this variant, through many different sources of analysis, appears to be between 50 to 75% more transmissible. So that means it's much easier to spread, and it also means that restrictions will really struggle to contain it, even if they're quite strict. So, for example, during our last lockdown, which was reasonably strict but didn't include school closures, cases with the previous variant of virus were spreading with an R rate of 0.9, which is below 1. So cases were actually declining, whereas cases with this particular variant of virus were spreading with an R of 1.45, which means that they were increasing quite fast, exponentially, even during those restrictions. So it really highlights that even with the kind of restrictions that we have under lockdown, it's very hard to contain more transmissible strains because they spread even with restrictions in place. So we need much more stringent measures to be able to contain this. The second impact that variants like this can have are that because the transmissibility is higher, we need much higher levels of vaccine uptake, for example, to be able to reverse pandemic growth. Because the herd immunity threshold, which is the level of immunity in a population that we need to reach to turn around epidemic spread, becomes much higher if the virus is more transmissible. So I'm very, very worried about this strain spreading across different parts of Europe, also because it becomes dominant very quickly. So if you allow it to establish into community transmission, it's a variant that can become dominant in a matter of weeks, which is what we've seen happen across England, where it spread from very low frequencies to frequencies of above 90% in a matter of, very few weeks, and rapidly spread across the region. So, you need to go hard and fast, and you have a very short window of containing it. And if you don't act during that time, after that, it's too late.
Yeah, I was discussing with our cameraman, who's not visible, before we went on here, whether we have it in Sweden or not. I'm actually not updated, but we were pretty sure that we have identified cases of it. So there were a couple of planes arriving from UK, and they let those people in, and then they said no more planes from the UK, which is like,
I mean, that's the thing. I think many countries acted on this too late. And the problem is that it's the kind of thing that you can have this variant in your country, and unless you have very good active surveillance, which many countries don't have, you could have the variant spreading across the population and not be aware of it until it's too late. So it really argues not just for closing borders, but also for very active surveillance of the variant at this point in time. And that doesn't mean that we need genome sequencing. We found that even certain PCR tests, which is the normal test for virus, can actually detect a sign of these strains in their readout. So it can be used for surveillance purposes to identify early rises in the frequency of this variant in any population.
Right, and there's a South African version also. I don't know what is the difference, but I read some, when you just, as a normal person, fiddle around with your internet flow of news, you don't know what's true and what's just fear mongering. But there were reports of this having a higher impact on children, and there were also reports of maybe the vaccine not being efficient against these new versions. Any comments on that?
Sure. So the B117 variant was initially observed to be more dominant in children and young adults under 19 years of age. And it was not clear whether this was because of increased susceptibility or transmission of the variant from children, or because of other factors. Now it's become a bit clearer, and it looks like it was dominant in children at that time because we were in a lockdown and schools were still open. So children were much more likely to transmit at that point in time. Since then, we've seen the variant actually becoming dominant across all age groups much more uniformly, which suggests that there's a more uniform sort of increase in transmission rather than any special susceptibility or increased transmission from children. But having said that, of course, it means that it's transmissible by everyone, including by children. So, we need to be very careful. The issue about escape mutations, yes, I think that is concerning, and it's actually more concerning probably for the South Africa variant because it carries a particular mutation that has, at least in the laboratory, been shown to be less likely to be neutralized by antibodies from people who have been infected by the previous strain of virus. Generally, we tend to say that the virus protein is quite kind of vaccines are quite resilient against changes to the virus protein because our body's immunity is very complex and it targets many, many different parts of the viral protein. So one small change in the protein or a few small changes are not likely to make proteins unrecognizable to our body. So it's likely that we will definitely have some sort of a vaccine response. But the question is it lower in quality or quantity. And I think that's an area that we don't know enough about yet, and it's being actively studied. But while that's being studied, of course, it's important to take vaccines if you are eligible and you can have access to them, because it's unlikely that it will fully escape the vaccine response.
Right.
I mean, perhaps the last thing I should add just about the mutation is just today, Pfizer has put out a report that their vaccine is likely to be effective against one particular mutation that's common both to the South Africa and the UK variant. But it's important to remember that this isn't the only mutation that we're concerned about in these variants, and there are other mutations that need to be studied before we can be fully confident about vaccine efficacy.
That's another argument I've heard from a colleague against somehow this let the virus spread and try to keep the healthcare system from collapsing. He was saying that the more viral spread you have until we get the vaccines in place and can crush this, the likeliness of having new dangerous mutations is correlating very strongly with the amount of spread you have in a society. So basically allowing spread is like really playing with fire here, because
yes, absolutely. And there's no coincidence that we've seen these adaptive mutations happen in the UK and in parts of the world where spread is high. Ultimately, the virus mutates as it reproduces or replicates. And the more we allow the virus to spread and transmit, the more likely we will see more adaptive mutations. And, the current mutations are not the first ones we've seen. And they've not just arisen in one place. Many of the mutations in these variants have been seen independently arising in different places. So these adaptations happen quite powerfully if we let them happen. And, we also have a previous more transmissible strain that spread across the globe over February and March. So given the number of adaptations we're seeing, there's a real risk that if we let this continue, we are going to see more adaptations, which are going to make containing this much harder. And we may even see mutations that, for example, escape vaccines better. So if you want to really protect our population and our vaccine efficacy, it's very important to actually focus on elimination, because New Zealand and Australia are very unlikely to have these issues of viral adaptation because they don't have virus circulating in the community, but we do.
Right. Okay, so final question. In the spring, the Swedish cases went up a lot, and then, to everybody's surprise, kind of turned down pretty quickly. And we don't know if that was related to spring coming in or what the hell happened to make the curve go down, because it certainly wasn't the NPIs, which were kind of constant. I mean, people didn't change their behavior that much. And now
schools open during that period?
Oh yes. Yeah. That's one of these things.
I thought that secondary schools moved to remote teaching or something like that.
They did close the universities, move to distance teaching, but everything else was normal and no precautionary measures whatsoever in school. Still not. I mean, I went to drop something at my kids' school, and I mean, it was like a normal day, kids climbing on top of each other, full in the stairway.
Right. And social distancing, because we hear, at least in the UK, we keep hearing that in Sweden, the compliance with social distancing is much higher.
No, this is part of a narrative
to
just sell the Swedish strategy, but it's not true.
Okay.
So now they enforced mask use after having refusing it. Up until before Christmas, they were saying that, no, we don't believe in that. Now people are going to wear masks. It's a recommendation in rush hour in public transport. And it turns out nobody gave a damn and went to the public transport without the mask anyway. So that's just a false narrative. There are many false narratives. We could go on for hours on that, but just to sell the idea that, because there's a lot of stake here, political influence and so on. Nobody wants to admit that they've been wrong, so they kind of cling to the idea that no, this is going to work out. And it seems like they're still hoping it. So that was what I kind of was asking you, because in the spring they did nothing. Many people went, oh my God. And then the curve kind of went down. Yeah, a lot of people died, but it wasn't this huge mountain of dead people that certain epidemiological models predicted. And now it's kind of the same. So now it's gone up. People are saying, oh my God. And these guys are like, it seems like they're hoping for a similar effect, that no, it's going to go down, and then they're going to go back to saying like, no, look, it wasn't so bad. People are panicking.
I thought they put restrictions in place once, cases started and deaths started rising very rapidly, quite late, but I heard that they started putting restrictions in place, particularly in more crowded cities.
No, what they've been doing is like marginal things.
Okay.
To make it seem, actually it's more of the thing that they came with some recommendations, okay, shops should be open, everything should be open, but you shouldn't go there. It's bad to go there. And then people went anyways, and then they started blaming the people for the failed strategy.
We've had the same.
It's more like a trick to get rid of responsibility rather than actually trying to do something to get the curve down.
I mean, I don't know why the cases came down in spring without knowing the Swedish strategy in detail. And of course, the news we get is somewhat, I guess, biased in the way that you mentioned. It's difficult to know what exactly is going on. So I can't say why that happened. Perhaps because the change in weather, people were meeting more outdoors rather than indoors. It's hard to say. But certainly, if they're expecting things to change now without actually taking action, I think that's incredibly unrealistic. It's not happened in any European country. If you look all across Europe, the curve has only been turned around once restrictions have been brought in place, and fairly strict restrictions at that. In the UK, we're still waiting to see that kind of turnaround, even despite having strict restrictions for a long period of time, despite, of course, schools were open and compliance with restrictions has been lower. But I think the idea that this will somehow sort itself out is frankly completely negligent and nuts. I think they have to take action, otherwise lots of people will die.
Yeah, well, lots of people are dying. Thank you so much, Deepti, for taking the time to chat with me here on our channel. It's been great.
And it's been really useful. I found out much more about Sweden than I knew before.
Yeah, well, if you have any questions, feel free to reach out at any point.
I've written threads about Sweden based on what the news reports, and then people have got back to me and said, this is not true. There are no measures in place here. And I've been like, yeah, but I referenced it from this article, and they were like, this is all nonsense. Yeah.
Yes, there's a lot of different narratives and a lot of potential influential powers, let's say, that have an interest in this narrative or that narrative somehow winning. So the amount of disinformation is just massive, and it's very hard to.
Yeah, I think nobody actually outside Sweden has a full picture of what's happening inside Sweden, because we just read the media reports, because actually, haven't really seen any kind of real research discuss what's actually happening there. So, I hear this from people on social media, but if you actually look at what the media is saying, it's completely different.
Yeah. Yes. Well, anyways, that's the topic of another chat, maybe. Thank you again, and thank the viewers for listening to us. Yeah, that's it. Over and out.
And thank you both of you so much for having me and for doing this.